Let's start off with the penicillins. So remember that penicillins are active on the cell wall. Now the cell walls, you can see them here, they have sites that are amenable to transpeptidation. This allows cross-linking of the components of the wall. And when you have cross-linking, you have a stronger wall. Now, cross-linking is created or facilitated by proteins that act on those peptidoglycans of the cell wall and links them together, much like a zipper does. Penicillins have a beta-lactam ring that binds to that protein, and for this reason, the proteins are called penicillin-binding proteins. So a penicillin-binding protein is where the penicillin is going to be active. Now, if you inhibit the penicillin-binding protein, autocatalysis of the cell wall will occur and the cell wall will break down. Now, the bacteria have developed defense mechanisms against the penicillins. So some bacteria have beta-lactamase enzymes. They're also called penicillinases in other parts of the world. Now, these beta-lactamase break down that beta-lactam ring. This is the mechanism of most types of resistance, and they're countered by the inhibitors of these enzymes. So clavulanic acid is an agent that inhibits the beta-lactamase. Now, we use that in combination with amoxicillin, and we sell it as amoxicillin clavulanate. Sublactam is another beta-lactamase, and we sometimes combine that particular agent with ampicillin, and we sell ampicillin sublactam. And tazobactam is the third one, and for example, we'll combine it with piperacillin as piptazo. Now, there are other mechanisms of resistance that bacteria will have against penicillin. Sometimes there's actually a structural change in the penicillin binding protein which renders immunity or resistance to penicillins. This is actually the mechanism of methicillin resistance, and it's become a real problem in our hospitals. Sometimes there's actually a change in the porin structure of the outer wall. So for example, the resistance of Pseudomonas to penicillins is a great example. The penicillin isn't able to penetrate because there's a change in the porin. Now, we'll talk about some narrow-spectrum penicillins that are out there. Methicillin, nafcillin, and oxacillin are narrow-spectrum agents. They're not used much anymore. I remember when we started medicine, we used to use methicillin all the time. Methicillin-resistant Staphylococcus has essentially taken methicillin off the table in terms of our choice because these MRSAs are resistant to all penicillins. Methicillin is also linked to interstitial nephritis. Nafcillin is associated with neutropenia. So these agents are falling out of favor, but they still do show up on our susceptibility charts. Now, ampicillin and amoxicillin you're probably quite familiar with. In fact, I would bet that at least some of you have been on these medications yourselves. These are wide-spectrum agents, but they are still susceptible to beta-lactamases. They are enhanced when combined with clavulanate, and in enterococcal infections, ampicillin is complementary with aminoglycosides. So in enterococcal infections, we'll often use combinations like ampicillin-gentamicin because they work very well together. That's called bacterial synergy, and I'm going to mention it again when I talk about gentamicin. Piperacillin and ticarcillin are stronger agents. These are very strong agents against gram-negative organisms. And once again, they are very complementary with aminoglycosides. So piperacillin, for example, will be combined with tobramycin to give a very strong gram-negative treatment. Once again, these drugs are susceptible to the penicillinases, so we often combine drugs like piperacillin with tazobactam to limit the resistance.